All right, hey guys, my name is Theo, and my project is validation and investigation of treatment response evaluation frameworks for PSMA PET-CT. Thanks, Jake and Michaela, for all your help so far. So to understand the core of my research, let's go back to square one, prostate cancer. So Australia has a very high incidence rate with about 26,000 diagnosed cases expected by the end of 2024. The 5-year survival rate for localized disease is about 96%, but this drops down to 30% for metastasized disease. So following a diagnosis, low-risk patients can opt for a form of active surveillance in which their disease is continuously monitored, but not necessarily treated. And high-risk patients can undergo a variety of treatments. So despite these therapeutic interventions, about 20 to 50% of patients exhibit what we call biochemical recurrence. So this is formally defined as rising prostate-specific antigen levels above this threshold post a radiotherapy treatment. So in other words, the cancer is still progressing, even though we've attempted to treat it. So this very simplified figure just shows that this is a crucial stage because usually the next progression of prostate cancer is after biochemical recurrence is one of metastases. So it's crucial to determine the extent and the spread of the disease at this stage. So how do we do this? Well, conventionally, we've used what we call screening methods to determine that extent and spread. We've used conventional bone scintigraphy and CT scans as seen on picture A. But the advent of and discovery of PSMA, which is a protein that's highly overexpressed on prostate cancer tumor cells, this has made it an ideal target for radioisotopes to be attached to, administered to the patient, and sort of illuminate the patient from inside out. And then we use PET and overlay that with a CT scan for anatomical information. And this has shown to have superior detection sensitivity and specificity compared to conventional methods. And on the picture on the right, actually, it was a bone scintigraphy, and the patient had a suspicious activity lesion in the femur, indicated by the red arrow. But the same patient actually underwent a PSMA PET CT scan, as shown in picture D, and there was actually no uptake of the PSMA protein. And so this patient did not actually have a metastasized disease, and their intent was changed from a palliative intent to a curative intent. So just for completion, in WA, we use these various PSMA molecules for diagnostic or screening purposes. And it's also found applications for therapy uses, with the FDA approving the use of lutetium PSMA for actual therapy. All right, so we have the ability to take these images. Now we can take a baseline image before a treatment, deliver the treatment, and then take another image after the treatment. And in this way, we can establish the response of the patient to that treatment. Now, this is crucial to establish an accurate prognosis, optimize the treatment plan, and just simply inform patients and their families. To this date, and more historically, qualitative assessment of these baseline and follow-up images have been performed, but it's been shown that quantitative, what we call response assessment frameworks, so using quantitative metrics to essentially define that treatment response in a more categorical and quantitative way, has been shown to reduce inter-observer variability and increase, of course, the reproducibility of our results. So to date, two frameworks have been developed specifically for PSMA. So the first one in 2016 was the PPP criteria, and it essentially just stratifies patients as having progressive disease or non-progressive disease based on the appearance of new lesions from baseline to follow-up. And the other one in 2022, more recent one, was a RECIP category, which stratifies patients into 4 categories. So they're either completely responding, partially responding to treatment, the disease is progressing, PD, or they have a stable disease. And this looks at both the appearance of new lesions and also calculates the changes in the total PSMA volume from baseline to follow-up. And really the end goal of these criteria is to associate these results with a clinical endpoint like overall survival. And it's been shown that patients with progressive disease generally have lower overall survival, very generally speaking. But so these criteria can be used to establish that prognosis that I just mentioned. So this brings me to my first aim. So we'll simply just validate the RECIP framework in a cohort of biochemically recurrent patients. Why do this? Well, the first paper that designed the framework by Gafford et al., top of the publications, was designed for metastatic castration-resistant patients, which is a much more advanced form of prostate cancer. And all the subsequent studies were largely using similar cohorts, and there was limited validation in biochemically recurrent cohorts, with actually only Jake Kendrick's paper. But his paper, the cohort actually had received a variety of treatments, and so it wasn't a very standardized approach to deriving the results. Now, furthermore, recently there's been contradictory findings. With Cooper et al., they found that actually this progressive disease category was not prognostic of overall survival for patients who had a lower burden of prostate cancer. So for 42 HSPC, so hormone sensitive prostate cancer, which is just a less advanced form of prostate cancer. And so we need to explore this. And then just for completion, there was also a new paper that introduced a sort of modified RECIP framework and that introduced additional metrics to take into account. So on top of the appearance of new lesions, total tumor volume, it also looked at the appearance of new lesions in new organs, so this new organ involvement, and also looked at the metabolic activity of the PSMA, so total lesion uptake. So we'll quickly just, so we'll acquire the baseline and interim PET-CT pairs. A clinician will have already segmented the lesions for us, so that would look like the image B and D. We'll simply calculate the metric, the total tumor volume and total lesion PSMA. Ideally, but this probably won't be the case, we want many physicians to review the scans to identify the appearance of new lesions from baseline to follow-up. And then we'll classify the patient response in the 4 RECIP categories. We'll estimate overall survival from Kaplan-Meier curves and use some form of statistical analysis to derive hazard ratios to sort of quantify that risk of death, which is associated with overall survival. All right, so that first aim is pretty basic, and it just uses the manual segmentations of the clinician. But we can essentially repeat this just using a fully automatic software. So that segmentation could have also been done semi-automatically. There's a software called PSMA that does this, but this requires manual corrections to be made, and this is time consuming. So actually, Jake Kendrick developed the first fully automatic total body scan for the segmenting metastatic prostate cancer in gallium PSMA using this sort of UNet architecture on the right. And it was shown to have high accuracy and sensitivity for detecting lesions at the lesion level. But again, there was only one paper that actually used this model to validate the prognostic utility of RECIP. And the paper did find that RECIP could remain prognostic with the use of a fully automatic segmentation software. But again, the cohort had received various treatments, and this was also specifically for gallium PSMA. So it remains to be seen if it's generalizable to other PSMA radiotracers like the fluorine 18, which will be part of our patient cohort. And also the model had actually quite poor accuracy at detecting lesions at the voxel level, because this is a very complex task. And so we'll be looking at sort of tweaking hyperparameters and investigating especially loss functions to essentially try to improve the model. So we'll arrange the scans between, fluorine, the different PSMA radioligands, and we'll perform the AI and manual segmentations. We'll spend the most time on this third point, assessing the AI performance using dissimilarity coefficients, investigating loss functions. And once this is done, then we'll apply the RECIP model and use some form of concordance analysis to quantify the difference of the results between the two. All right, so the third aim, also quite basic. It's kind of, we're just going to validate the other framework in the same cohort and compare those results to RECIP 1.0. Now, why do this again? Well, PPP has only been validated once, actually, for biochemically recurrent patients. And there only remains one sort of comparative study that tells you, okay, RECIP is probably better to use in a more advanced patient cohort than PPP. But this is the only comparative study. And so there just remains no general consensus on how to best use either criteria, when to use them, why to use them. So we'll, after validating PPP, we'll really try to narrow down that criteria for using either one. So yeah, quick methodology. So we'll just categorize the patients according to the PPP criteria, and then we'll use concordance index to evaluate the difference in prognosticability of the two. Now, at the end of this, so we've sort of validated both frameworks. There's also a large body of research that I'll probably get onto as well, is to do with radiomic features. So the RECIP framework, it calculates a metric called the PSMA TV, so the total tumor volume, and it does this by using a liver-based threshold approach. But some other papers have also calculated this metric in another way and found that to be also prognostic of overall survival. But then again, other studies have found this other metric, SUV mean. So instead of looking at the changes in PSMA volume, we look at the changes in the lesion SUV mean from baseline to follow-up. And this was shown to be very prognostic of overall survival, actually by Jay Kendrick's paper as well. And so it just remains, I just put this to illustrate the fact that, well, if this is the case, why not try to introduce these into, for example, RECIP 1.0 or into even a new response assessment framework? Because if it's more prognostic of overall survival, then it can only be better for the patient. So we'll explore this sort of additional field of research. The last aim is thanks to our access to also FDG PET CT scans. So FDG is based on the glucose metabolism of the tumor cells. And there's actually a conundrum in clinically that in very high disease stages, patients can exhibit PSMA negativity, so they're not showing up PSMA expression on PSMA scans, with FDG positivity. This has a huge impact on the type of treatment suitable for patients, so they might not be able to receive lutetium PSMA therapy, and also on our evaluation of the treatment response. We might miscategorize or misclassify patients as, having a stable disease when in fact the FDG glucose metabolism is sort of hiding behind that PSMA negativity. So what we'll do is just extract a bunch of biomarkers from the FDG scans. We'll assess the prognostic utility of each for overall survival. And so we will have determined sort of the suitable metrics that could be incorporated into a response assessment framework. And then we'll assess the impact that this has on the RECIP categorization of patients. So we'll be asking questions like, does a hybrid response evaluation framework provide a more accurate prognosis? Likely to be yes. Does RECIP misclassify patients as having stable disease when FDG positivity suggests otherwise? And also, is discordance even a problem for biochemical recurrence? So we'll just be sort of investigating that. All right, so to summarize the 4 aims in a sentence, so we'll validate robust treatment response evaluation frameworks for the assessment of prostate cancer from PSMA PET CT, and investigate the integration of AI, various imaging biomarkers, and FDG PET metrics and their impacts within these frameworks. Basic challenges, the data quality might be noisy, and the quantity, we don't have a very large sample size, so these can both affect the accuracy of the segmentations, both from manual segmentations and the AI. We won't be able to actually quantify the inter-observer variability of the manual segmentations because it's only been performed by one expert nuclear medicine physician. And also, there's a prognostic variability of FDG PET biomarkers. So I fear that this might be probably the more problematic one for AIM4, which is that we're looking at a cohort of BCR patients, which is not a very advanced stage. And so that discordance that I was talking about might not actually be that significant at that stage. And so the significance of each biomarker and their association with overall survival might not be also that significant. And so it might be hard to evaluate the prognostic utility of each. But that's to be seen. All right. And that's pretty much it. Thank you.
Work. Thanks, Theo. I have a couple of questions, so I might just jump in. I don't see anyone else with their hand up. So I guess the first question I wanted to ask was, you've got plenty of aims here, and one of your aims actually includes retraining the AI model that I have.
Yeah.
How feasible do you think it is to get all of these aims done in the project time that you have available?
I actually think it's very feasible, because I've made it seem a bit more complex than it actually is. But for example, when I'm validating RECIP and these frameworks, I'm only really extracting one radiomic feature, which is the PSMA total volume, and then making the statistical analysis. But I don't think that's going to take me too much time. I think it's just mainly my fourth aim, which will, because I'm not even sure what my approach really will be for this. So that will probably take the most time, but I think I could get these done. Yeah.
Okay.
Hopefully.
So that probably leads nicely into my next question, actually. I think your fourth aim is a very important one, because something that I've suspected for a while is that PSMA specific frameworks like RECIP and PPP will have less value in patients with substantial amounts of PSMA negative disease. My question is just regards to a potential cutoff point for the metabolic tumor volume. So if we're looking to sort of analyze differences between groups, what do you think would be a sort of appropriate cutoff point for the metabolic tumor volume, for example?
As in like a specific percentage, or?
So the metabolic tumor volume would be like a volume, so like in mils, for example.
Right. Yeah.
Do you have an idea as to what an approximate cutoff point would be if we were to look at some groups?
No, I'm not quite sure. I thought you meant, sorry, the change between baseline and follow-up. So that's why I said percentage. I haven't looked quite into that. I haven't looked into the individual FDG metrics yet, so I'm not quite sure what they're going to look like at all. And I'm just not even sure that this discordance is going to be significant in our patient cohort. So I haven't really looked much into that.
That's all right. That was a relatively difficult question. So what I'd recommend is there's a clinical trial called the therapy trial. And there was a biomarker analysis conducted on that, which showed that patients that had a greater than 200 mil FDG metabolic tumor volume, they had a much worse prognosis than patients with less than 200 mils of FDG positive disease. So I suspect that a cutoff like that, based on a clinical trial, would be a good one for us to investigate.
Okay. Yeah.
Yeah. And one more question before we move on to Ashleisha. What advantages do you think there would be for using an AI model to segment this disease, as opposed to undergoing a semi-automated approach with a nuclear medicine physician?
Well, the one that stands out firstly is always the time consuming aspect. If we can do this automatically, then also this means that if we investigate other biomarkers and find SUV mean, for example, to be more prognostic of overall survival, but at the moment, the only thing that's hindering that application is that calculating SUV mean is time consuming, right? Because you have to look at all the voxels in the body. Well, if we developed a software that can just do this automatically, then we could use also these additional metrics, which are more prognostic of overall survival. And so just on top of that, on top of saving time, we're also actually increasing the accuracy of the prognosis, I guess. Yeah. And also just reproducibility. That's a big one.
Yeah. Thanks, Theo. I was actually just going to mention that reproducibility is a huge one as well. So
yeah.
Excellent. Thanks, Theo. Ashleisha, do you have a question?
Yep. Thanks, Jake. Thanks for the presentation, Leo. My question was just regarding, do you think this framework can be integrated into routine clinical practice? And has there been any examples where to some extent this has been done anywhere?
I don't think this has been clinically implemented anywhere just yet.
Yeah.
I think it's also to do with the fact that there's quite a lot of criteria to be examined, and so to do that for individuals, and to do that for each pair of baseline and interim PET CTs is super time consuming. But I mean, hopefully with my research, I mean, I do want to just make this more and more clinically implementable, because that's the ultimate goal of all this research. Yeah.
Yep. Do you think there are any steps that can be taken to make it closer to like clinical implementation?
I think just further validation of the models, because it hasn't really been validated in sort of these standardized treatment, standardized cohorts. So we're not sure if we can actually implement it just at this stage. So just more research on it, and also maybe the AI part can, might make it more conducive to clinical use, because it's just less time consuming.
Yep, sounds good. Thank you.
Thanks.
Excellent. Thanks, Theo. That looks like Martin.
Sorry, one more, Jake. Sorry. Yeah. Thanks, Theo. This was great. And just reiterating Jake's question about the number of aims and how ambitious your project is. It's great that this work's continuing. It's going to expand. But even that fourth aim you've got up there now is going to be a reasonable amount of work. I guess if you are the aims you've written in the order you are prioritizing them, that you're likely to tackle them?
No, there's no real, because for example, the clinician hasn't actually performed all the manual segmentations just yet. So I'll probably get onto using the Jake's deep learning model first. So complete aim 2 first, and then go back to aim 1. But yeah, there's no, I don't really have a real timeline just yet for the individual aims. They kind of overlap.
Sure. You might just want to keep tabs on progress on each of them, and if you abandoned one or two, I don't think it would have a huge impact on your overall project. There's still plenty of work there.
Yep.
Excellent. Thanks, Martin. And thanks, Theo. Excellent
Awesome.
presentation. Plenty
Thank
of
you.
work ahead of you.
Yeah.